Okay, so we're going to talk about heart murmurs, one of my favorite topics. The reason why is because even as a medical student, you can pick up heart murmurs with your stethoscope, impress the people you're working with because, you know, they forget about heart murmurs sometimes, and they just leave it up to the echo machine, but you can do it with your stethoscope. So here's how you need to think through heart murmurs on your test. First, you need to, there's two things that are important: timing, a couple little keywords for a few heart murmurs, and location. Those are the main things that are going to give you the answer. They're going to tell you the answer in the question stem with those three things. So the first thing you do is timing, and it splits off into two main branches. You've got diastolic murmurs, and you've got your systolic murmurs. And the way that you remember which ones are diastolic and which ones are systolic is think about the heart during diastole or systole, and which ones are closed and which ones are open, which valves are open and which ones are closed. So in diastole, which valves are closed? Right, your aortic valve and your pulmonic valve. So if you're getting a murmur at that time, you could have aortic regurge, so blood coming back through the aortic valve, which should be closed. Pulmonic regurge, same thing. Mitral, now what about the mitral valve? Should it be open or closed during diastole? It should be open, right? And so if you're getting a murmur, it's because you have stenosis. It's not opening all the way. You've got this little open door that blood is going through and it's making noise. That's your murmur. So same thing with the tricuspid. Tricuspid stenosis. Whoops. Okay. So aortic regurge, pulmonic regurge, mitral stenosis, tricuspid stenosis. Your systolic murmurs. So all you have to do is remember one. You can flip it, because in systole, the aorta should be open or closed, open. And if you're getting noise, because you have stenosis. So aortic stenosis, pulmonic stenosis, same reasoning. Now mitral and tricuspid, they should be closed during systole. So if you get a murmur, then you have mitral regurge or tricuspid regurge. Okay? So that's our first split. The last little thing that you have during systole is septal defects. So I'll put that on the side here. Septal defects. Because during systole you have a lot of pressure and you have blood moving through these septal defects. So we'll start there. We'll just keep these out of the way. What are your two types? Ventral septal defects and atrial septal defects. Okay, so these are the things that you're going to see usually in pediatric cases. This is when you have a hole between the two ventricles, so you're going to get a really harsh, that's what you want to remember with this, harsh holosystolic. Those are your buzzwords, your harsh holosystolic. Okay? For your atrial septal defect, the main thing that's going to give you the answer is fixed splitting. Of S2. Okay, so let's think that through. Why do we have fixed splitting of the S2? So normally, this is normal. You have an S1, and then you have your aortic valve closes first. That's your A2, and shortly after your P2. That's when your pulmonic valve closes. So this is during inspiration. Okay. During expiration, what you'll have is there'll be less split. So they'll be right on top of each other, essentially. You won't be able to tell them apart. So why during inspiration are they split apart a little bit? The reason why is because during inspiration you increase, so let's talk about inspiration. So during inspiration your your lungs or your chest wall is expanding. You're creating negative pressure in your chest cavity. And negative pressure, think of that just sucking the blood up from your lower extremities. It's sucking the blood up through the inferior vena cava. So it's sucking all that blood back up into your chest, and it's going back into the right atrium. So all you have to do is just think inspiration, more blood through the right side of the heart. Okay? So during inspiration, when you have more blood through the right side of the heart, you have more blood pumping through this pulmonic artery, or pulmonic valve, and the pulmonic artery. So it has delayed closing because it needs to accommodate all that extra flow. During expiration, you're having less volume go through the pulmonic valve, less volume go through the right side of the heart, so you don't have that splitting. So in ASD, you have a left to right shunt. Okay? Because during systole, you're getting some of that blood that from the left atrium pushes back into the right atrium. Because the right atrium has a lower pressure than the left atrium during systole, and you've got that hole in between and the pressure equalizes. So blood goes from left atrium to right atrium. So you have a normalization. So what happens is, if you've got that, you'll have this wide fixed splitting. Because if you're pushing more blood into the right atrium, it's just like inspiring. You're increasing the pulmonic circulation. You're increasing the blood that's flowing through that valve, and so it has to close a little bit later to accommodate that. So it doesn't matter whether you're inspiring or not. You're going to have this wide splitting, because whether you're inspiring or you're not, you're still having more blood flow through the pulmonic circulation. So you're going to have that closing later than the aortic valve. So wide fixed splitting, ASD. That's what you need to remember. Wide fixed split, ASD. Left to right shunt. That's what you need to remember. Okay, so we've covered ASD, we've covered VSD. Let's stick with our systolic murmurs and break them down. So first, what's going to give you, once you split down whether it's systolic or diastolic, you need to think about location. That's important here. So this is my little hokey pokey chest here. Here's the umbilical cord, umbilicus. Okay, and you've probably already know this, but I'm going to draw this out. There's your mitral valve location, tricuspid valve location, aortic valve location for auscultation, and pulmonic valve. Everybody has their own way of remembering this. There's your nipples. How I remember this is my tits are perfect. It's a little dirty, right? But all good mnemonics are dirty. My tits are perfect. You just start lower and you circle around. My tits are perfect. M-T-A-P. So location and timing. Those are the two most important things in figuring out what kind of murmur a person has on your test. So these aortic. These are both second intercostal spaces. So these are both second intercostal spaces. It's just left to right. So if someone says they hear a systolic murmur, so you go over here, it's either ASD, PS, MR, TR, and it's over the left intercostal space, what is it? Right, pulmonic stenosis. You know it's pulmonic because it's there, you know it's stenosis because it's systolic. It's just that simple. This is going to be the lower left or right sternal border. It doesn't matter. You can hear it on the left or the right. It depends on the person. So all you have to know is it's lower left or lower right sternal border. Here the mitral valve. In your question stem, you'll see it say the fifth or sixth intercostal space on the mid-clavicular line. Okay, here's your mid-clavicular line, and this is about your fifth or your sixth intercostal space. Oops. Okay, so write this down. This is important. Timing, systolic or diastolic, location. That'll get you 90% of the way there. Okay, let's talk about how to get you the rest of 10%. Because I really believe that if you stick to this method, you'll get every single murmur question right on your test. Okay? So let's see here. So we've talked about location for these. Let's talk about special characteristics. So aortic stenosis. So for aortic stenosis, you'll have radiation to the carotid arteries. You'll also have early systolic click. Okay, think about why that is. So if you've got a stenotic aortic valve, it's crusty, it's tight, it's closed shut. It doesn't want to open very well. So when you build up that pressure in your ventricle, it's not going to open right away. It's going to kind of, like a rusty door, you have to push on it a little bit more. So a little bit in the systole, it'll pop open. And that's your early systolic click. Okay? Another thing you're gonna get on your question test is either they'll call it this, but probably not. They'll just describe it. It's called pulsus parvis aortatis. What that is it's Latin for a weak and late pulse. So think about that. Why that is. You're listening to the heart. You have this big, muscly heart that's been fighting against this stenotic aortic valve for a long time. So it's hypertrophied, and it's got these big beats and choo-choo, choo-choo, choo-choo. But then you feel the pulse, and it's kind of weak, and it's like actually a little bit late relative to the listening. So while you're listening to the heart, put your fingers on the radial pulse, and if you feel this pulsus parvis aortatis, so weak and late pulse, think about aortic stenosis. And just quickly, what causes aortic stenosis? There's two main things you're going to need to know on your test. Old age. So people that are old get aortic stenosis. It just happens a lot. It's from calcification of the valves. And two, congenital bicuspid aortic valves. So you have two leaflets instead of one. You're born that way. And because you have two leaflets instead of three. You have two leaflets instead of three. Because you have that abnormality, you get increased, basically you get increased damage of those two valves. And so you get this inflammatory response there, which causes calcification. So two causes: old age and bicuspid aortic valve. So pulmonic stenosis. What you need to know about that is it's part of tetralogy of Fallot. You can review tetralogy later, but that's the main thing you'll be tested on for pulmonic stenosis. Also, just generally, what causes right-sided valvular heart disease? So there's a couple things you need to think of. So the right-sided valves are the pulmonic valve and the tricuspid valve. The things that causes damage to those valves are IV drug abuse and rheumatic fever. So quickly, IV drug abuse, why does it cause the right-sided heart? Because you're injecting drugs, you're injecting dirt and crap and everything else in your veins, returns to the right side of the heart, and those are the first valves that the dirty blood passes through. And then it kind of gets filtered through in your lungs, so your left side of your heart doesn't really get the junk spattered onto it that the right side of the heart does with IV drug abuse. The other thing is rheumatic fever. So quickly, just a quick review of rheumatic fever. Autoantibodies after group A strep infection. But let's talk about specifically what valves it affects. First is the mitral valve. And with rheumatic fever you can get any valve can be involved, and you can either have stenosis or regurgitation. But the order of prevalence for the valves involved is this way. So first is mitral. That's the one it likes the most for some reason. The second is aortic. Okay, so actually I forgot something. So aortic stenosis, in addition to old age, bicuspid aortic valve, mitral rheumatic fever can also cause it. And third valve that it prefers is the tricuspid valve. Okay. Those are the three valves in order of preference for rheumatic heart disease. Okay. So what you need to know about mitral regurge and tricuspid regurge. First of all, let's talk about how they're similar. They're similar in that they're both holosystolic. Okay, holosystolic here, holosystolic for septal defects. With aortic stenosis, pulmonic stenosis, you'll have this click because it'll open up a little late, like that. But with regurge, it'll be holosystolic. So what makes them different? So first with mitral regurge. So the things that make mitral regurge different from tricuspid regurge are not only location, which will give it away most of the time, but if they don't give you location, or if the location is kind of confusing, you can think about radiation and what makes it worse or better. So mitral regurge radiates to axilla. Radiation to the axilla, it's mitral regurge. Close the book. That's what it is. Also, think about what will make this worse. Mitral regurge is caused by blood flowing back through the mitral valve during systole, right? So anything that increases the afterload, so increases the afterload well, let's look at it this way. So imagine this is your left ventricle, and your left ventricle, that's what it is. Also, think about what will make this worse. Mitral regurge is caused by blood flowing back through the mitral valve during systole, right? So anything that increases the afterload, so increases the afterload well, let's look at it this way. So imagine this is your left ventricle, and your left ventricle has two options, either through the aorta or back into the right atrium, or left atrium. Okay? That's where blood's going to go when you have a mitral regurge. If you have an increased pressure here, that's synonymous with increased afterload. So you have high hypertension, you have coarctation because this is pinched down, you have any of those conditions. You also have aortic stenosis. That's going to increase the afterload on the left ventricle, and it's going to favor pushing blood back into the left atrium. So things that it increases with increased afterload. So things that increase the afterload are, when you examine someone, will be maneuvers like the hand grip or squatting. Okay, and squatting is different than going from standing to squatting. That's a little bit different. Well, this is sustained squatting. So I have someone squat, they stay there for a while, and then you listen again. If it's better, then it's probably not mitral regurge, because mitral regurge will get worse with squatting. Okay? Tricuspid regurge. The book says it radiates to right sternal border. That's not going to be your question. That's kind of silly because it's there on the left sternal borders where you hear it loudest. Radiates to the right sternal border. I don't know. That's kind of not testable. But what is testable is that it will increase. Tricuspid regurge will increase with anything that with increased right heart flow. So we talked about that before with splitting, but what sort of things increase right heart flow on exam? Taking a big breath in, because you increase that intrathoracic negative pressure, you suck all the blood back to the heart. So inspiration, right-sided murmurs increase. Alright, so let's talk about our diastolic murmurs. I need some room, so I'm erasing this. Okay. So here's what you need to know about the right-sided, or the diastolic murmurs. So with aortic regurge, what's happening? Blood is coming back into the left ventricle when it's not supposed to during diastole. Okay, so you know where you're going to hear this. You're going to hear this on the upper right sternal border, right? I just did the my tits are perfect thing on my own chest, because I always do that, and so I'm never wrong. I wouldn't say never, but less likely to be wrong. So this, what you'll hear in the question stem is a blowing murmur. You don't want to hang your hat on that, though, so you want to look for other things that would be associated with the aortic regurge. So the main thing that you can hang your hat on is this widened pulse pressure. And that makes sense because during the peak of systole, you're having your systolic blood pressure, right? So let's say it's 120. During diastole, that aortic valve should be closed, and the pressure that you get during diastole is just this reservoir pressure of the the springiness of your arteries. So if you have that aortic valve staying a little bit open and blood flowing back into the heart, you're going to have a decrease in your diastolic pressure. So that will widen your pulse pressure. You have the same systolic, but less diastolic, so you have a wide pulse pressure. So you have, instead of having something like 120 over 80, you're going to have something like 120 over 50. When you see widened pulse pressure, and you've got a diastolic murmur, think, whether they give you location or not, think first of all about aortic regurge, okay? Pulmonic regurge, you won't be tested on this, so don't worry about it. Not gonna be on your test. It's a lot like aortic regurge, except different location. You won't have this pulse pressure. Don't worry about it, other than knowing that it's a right-sided valve disease, so it can be caused by what? IV drug abuse. That's what you'll need to know. And also what? Rheumatic heart disease. Okay. Mitral stenosis. This is totally testable and will be on your test most likely. Mitral stenosis, the main thing that will give this away on the test is this opening snap. Oops. So keeping snaps and clicks kind of straight in your head. Remember that aortic stenosis, you have this opening or early systolic click, and like I said, it's when that pressure builds and it finally that stuck valve opens up, goes pops open. Same thing with the mitral valve. So if this is stenotic, it needs a little extra pressure to open up, and it opens up in the middle of diastole. So S1 here, S2 here. This is where you'll get that snap when it finally opens up, and then you'll get your rumble through that stenotic valve. Opening snap, mitral stenosis. Just plant that in your memory. Don't ever forget it. And then mitral stenosis from an immigrant who hasn't had vaccinations. What is it? Rheumatic heart disease. Right. You need to know that. Okay, tricuspid stenosis. Again, you probably won't see this on your test. It's a lot like this. Don't worry about it. But know that it is right-sided heart, IV drug abuse, rheumatic fever, because it can go anywhere. Okay, and remember, what's the order of operation or the order of prevalence for rheumatic fever in terms of which valves are involved? Mitral first, then aortic valve, then tricuspid. Okay, mitral, aortic, tricuspid. It can be regurge or stenosis. So lastly, let's talk about maneuvers. Okay. There's basically two types of maneuvers. One type changes afterload. The other type changes preload. Okay? We've already covered a lot of these, so this is really just consolidating the information. So what changes preload? So preload is supplying the blood before. It's diastole, it's the end diastolic volume, right? So when you're breathing in, inspiring, this is our third time going over it, so I expect you to have it by now. You're increasing preload So an example of this is inspiration increases preload to right heart and enhances right heart murmurs. Laying supine also enhances right-sided murmurs. So inspiration, increased preload to right heart, increased right-sided murmurs. Okay. How do you decrease preload? Well, expiration, right? Let's do the opposite. Expiration. So expiration will actually enhance left-sided murmurs. And not drastically, but it will. And the way I remember this is I think about when I'm breathing out, my lungs are collapsing and I'm kind of squeezing all the blood from the lungs back into the left heart. And increased volume over the left heart means it's moving across those bad valves, means I'm going to get increased murmur. Okay? So that's the main ones that change preload. Okay, inspiration enhances right-sided, expiration enhances left-sided. Okay, things that change afterload. So what are we talking about afterload? We're talking about pressure, the pressure against the system. So, so it's mostly going to be pressure in either your pulmonic circulation or your aortic, right? So how do you increase aortic or your systemic? Let's say this. It's better to say systemic. Okay. Systemic and your pulmonary. Okay. So how do you increase afterload in your systemic system? That's your hand grip. So this includes your hand grip. This includes squatting, sustained. Increase systemic afterload with hand grip and squatting, okay? And if you increase the systemic circulation, you're decreasing the amount of flow across the valves, so you're going to have less left-sided heart murmurs, okay? With the pulmonary system, how do you increase the afterload of that? So how do you cause basically pulmonary hypertension? Well, it's kind of hard to do that. That's basically if someone has pulmonary hypertension or not. And you don't really need to worry about this one for your test. But you need to know about hand grip and squatting. Valsalva. Let's talk about Valsalva real quick. I skipped it because it's tricky and I forgot about it, but now we're going to talk about it. So what is Valsalva? I'm going to be honest with you, I didn't really clearly understand Valsalva until my third year of medical school. So Valsalva is where you tell someone to close their mouth, plug their nose, and blow out like they're blowing up a balloon. And what that does is it increases intrathoracic pressure, and it increases parasympathetic tone. Okay? So we know that when you increase the thoracic pressure, intrathoracic pressure, this is why you Valsalva when you go in the bathroom, right? You're squeezing your abdomen, you're squeezing your chest, you're creating a lot of pressure in your abdomen and your chest, and you're just squeezing things out. Okay? So when you're doing that, you're also squeezing what out of your chest? Blood. So you're getting decreased return to your right heart. So that's going to reduce the amount of murmur in right-sided murmurs. So this is another way this is the same thing as exhaling, but it's exhaling plus. It's the same mechanism for either accentuating or reducing the volume of the murmur. Okay, this parasympathetic tone, I'll just mention it, it's not important in murmurs, but when you Valsalva, what happens to your heart rate with increased parasympathetic tone? Decreases your heart rate, and it can decrease your blood pressure. That's why people pass out when they're going to the bathroom sometimes when they're older and they have poor vasovagal. This is the vasovagal reaction kind of thing. Okay, so that was kind of a whirlwind of murmurs. To recap the most important things, I'll do that with a red pen here. Start with timing. So is it systolic or is it diastolic? That will help you split, okay? Second, location. They'll give you the valve. They say it's in the upper right sternal border. You know that it's aortic. You know it's aortic. So you just got to figure out whether it's stenosis or it's regurge. And you can tell that out with whether it's systolic or diastolic. Boom, you've nailed it. Last thing, they try to mess you up. Look for keywords like harsh holosystolic, fixed splitting, okay? What else? Aortic stenosis had the early, early systolic click, okay? That's a keyword, key phrase. This has the opening snap. Mitral stenosis, opening snap, boom. The aortic stenosis also has pulsus parvus et tardus, or late and weak pulses, okay? And lastly, your maneuvers, your special maneuvers. Okay, so that includes things that increase afterload. So what increases afterload? That's your hand grip, that's your squatting. Another thing that decreases afterload is if you go from squatting to standing, because all of a sudden you go from high afterload to low afterload. But don't worry about that one. That one's not till step 2. Things that change the preload. So breathing in deep will increase right-sided flow. So that will increase the preload, will increase right-sided murmurs. And things that decrease preload are Valsalva, exhaling. Okay. So I hope that helps with figuring out all your murmur questions. I think that if you stick to this, systolic versus diastolic, location, keywords, maneuvers, you will nail every single one of your murmur questions. Okay? Good luck. So we didn't talk about hypertrophic obstructive cardiomyopathy because it's kind of the exception to a few rules. So you'll need to study that one on your own.